Good evening, everyone. It's greetings from Indian Academy of Echocardiography. We are having the next or the latest edition of the monthly education series of IAE, which have been sought after for so much time. And this time we are having some stellar speakers and talking on some topics which is not usually covered in our usual meetings, because usually our meetings are usually focused on echo. So as we all know, this series is actually focused on multimodality imaging, which is actually the most felt need in the current cardiology practice. So today we got three speakers. We got the first topic is cardiac CT, the finer points of cardiac CT, especially the things which we cardiologists don't usually are not very much aware of. That is how you reconstruct the image and how you take care of the artifacts. For speaking on this, we got none other than Dr. Nitin Burkale. And the second topic we'll be having is mitral stenosis, but a different aspect. We all are familiar with the rheumatic mitral stenosis. So let us talk about something different, that is the non-rheumatic mitral stenosis. And for speaking on this, we got our own dear Dr. S.K. Parashar sir. And there will be some interesting and challenging cases which will be presented by Dr. R. Shanmugasundaram. So let us start off with cardiac CT. For speaking on this, we got the master teacher or someone who can educate us the best on multimodality imaging and cardiac CT. Dr. Nitin Burkale, sir. Sir, please go ahead. The floor is yours.
Thank you, Dr. James Thomas. I will just share my slides first. Okay. So, yeah. So we have this. So we had these lectures. We have got these lectures of CT. We started on 2nd July, and 1st October is the part 4, and part 5th will show the clinical cases, which Dr. Johan Christopher will show. And this is an academic non-commercial activity, and delegates are requested to go through the original lectures because this was a series. So we discussed about the instrumentation and the physics of CT, because we should know how the image is created, and this is the last part of it. And as you can remember that these are our credits and acknowledgements. And as those who have attended the last lecture, we had discussed how the CT improves its spatial resolution and how it improves the temporal resolution. And today we are going to cover the volume coverage of the heart, because the heart is a larger organ, and the CT has to cover the entire length of the heart, and that is also quite challenging, and that we should be knowing. So now let us consider the volume coverage by the cardiac CT. As you know that you have to capture the entire heart from base to apex, but that entire picture is not a snapshot by the Gander rotation. What it does is that it takes a sliver of the heart volume, then it takes the next sliver of the heart volume, and then it takes the next sliver of the heart volume, and then it generates the entire cardiac volume. So volume coverage is another challenge of the cardiac CT imaging. So how does it do that? As we know that if you go on increasing the number of detectors in the Z direction, okay, whether 64 slice, 128 or 328 slice, then obviously you will have larger and larger volume coverage from the base to the top of the heart. So when you are using a 64 slice scanner, you are covering in one Gantt rotation around 40 millimeters of the heart. So that is around 4 centimeters. And as you know, from the base to the diaphragm, you have got around 12 to 14 centimeters to cover. So you may need 3 volume data sets.
with a 64 slice scanner to cover the entire heart. So if we look at the 4 slice, 16 slice, 64 slice, or more than 64 slice, the typical length that you are covering with a gantry rotation is less than 20 millimeters, or between 20 to 32 millimeters, or around 40 millimeters for 64 slice, and 160 millimeters when you are using the 320 slice scanner. So when you are using the highest detector row of 320 scanner, then actually just one gantry rotation, you are covering the entire cardiac volume. So truly, in one cardiac cycle, you can acquire the entire data set for the entire heart. So this is again, we are keeping it in perspective that if we are using four slice CT versus 16 slice CT versus 64 slice CT, and this is the distance that we have to cover from the base to apex. And if we are using the helical scan with a pitch of 0.33, and if your gantry rotation time is 0.5 seconds, then it would have taken 48 seconds for 4 slice. It would take 12 seconds for 16 slice. It just takes 6 seconds or 6 heartbeats for 64 slice. So this is very much feasible because this is a very short breath hold. So in a very short breath hold, a 64 slice scanner at the gantry rotation time of 0.5 and a pitch of 0.33 can cover the entire set of the entire volume of the heart in just 6 heartbeats, and which is very much feasible even if you have a very short breath hold. The same mathematics has been shown for the 320 slice CT, where you can cover the 16 centimeters just in 1 second, because that is how, because you can get the entire heart in a single heartbeat by just one gantry rotation. So suppose if we have the irregular heart rate or lot of frequent ventricular premature beat, then obviously we will not be catching the same phase during the helical scan. And when we stitch that data together, we are going to get this kind of a step artifacts for the wherever you are stitching these volumes together. Now, as we know that in a sequential axial cardiac CT coronary angiogram, we are using in a 64 slice CT, we are using 7 heartbeats, because in the first heartbeat, you turn the radiation on in the late diastole. The next RR interval you use for the table to move, and then you fire for the second set of volume. Then again, you move the table, then you take the third volume, and then the fourth volume. So probably it takes around 7 heartbeats. So a short breath hold in a step and shoot, or the sequential axial cardiac CT coronary angiogram. So the thing is, if you have a wider beam, like if you go from 64 slice to 320 slice, obviously you will need a lesser number of heartbeats to cover the heart. So the thing is, there is a if you want to achieve a very large coverage of the heart in a very short time, there are two ways of doing it. One, obviously, to have a very large array of detectors, like 320 detectors, so something like covering 160 millimeter or 16 centimeter and just one rotation of the gantry. So this is achieved by the Toshiba Aquilion, that you have a single bit acquisition. You don't need any breath hold in this. Or the other way of doing it is by the dual scanner Siemens flash mode. Now, what does it do is that it has got two X-ray tubes, as we discussed together just now, and then it goes into a very high helical pitch, and it can acquire the entire cardiac volume in one cardiac cycle. And we'll see how both of these are achieved. So this is the Toshiba Aquilion with 320 detector row. and you have got this complete coverage of the heart in one rotation in one cardiac cycle. So the thing is, there is no table movement. The radiation is less. You get a very uniform contrast enhancement, and you can do whatever you want. You can do the multi-cycle reconstruction. It improves the temporal resolution. It is also useful in the pediatric patients and also useful in atrial fibrillation patient because you are acquiring the entire data in just one cardiac cycle. The Siemens dual scan, the dual tube mode has got a way of scanning the heart in just one cardiac cycle, and it is called as flash mode. So what does it do is that it's a helical scan. Okay, both the tubes are active, and the table moves really fast, so there is a very high pitch, and you acquire the entire data set in a time window in the late diastole. So the thing is, because of your high pitch, you cover the entire heart in this small window period, and since the table speed is very high, obviously you are going to have a very high pitch. So one would ask that if the detector pathway is so spread out, aren't we losing some of the volume data between these two adjacent spiral pathways? But the thing is, it is interesting that this is only the spiral pathway of one X-ray tube. The second X-ray tube fills up the spiral data set in between these two adjacent spiral detector movement of the first X-ray tube. It's like both the X-ray tubes are having their own spiral detector pathway, and they become complemented to each other. So each one is acquiring its data independent of each other, and they are filling up the space in between the spiral of the other tube. And that is why you can achieve very high pitch scanning of the heart in just one cardiac cycle. So that is how the tube 1 and tube 2 acquire the data sets independent of each other, and with a fairly larger time window period, they can acquire the entire cardiac volume in the late diastole, and that may be sufficient for the coronary angio or the reconstruction of the coronary angio images. So putting it together, this is the time window when the radiation is on and you are having a very fast motion of the tube, and also you have got a simultaneously dual source rotation of the gantry, and you create an image from both the spiral movement of the X-ray tube and its detectors, and the distance between the first and the last image is around the 300 milliseconds. And the thing is, the whole so the pitch used is very high, like 3 or 4. It is suitable for regular heart rates less than 65 beats per minute. That is important because you want a little wider imaging window in the late diastole. So you want a really low heart rate, but it is a very quick way. You don't need any breath holds. And what the 320 detector array a CT scanner can acquire in one heartbeat, you are achieving with the lesser number of detector arrays, but using two sources, the two detector sources and the two X-ray tubes, and with a very high pitch. So finally, summary of the protocols. We have the retrospective ECG gated, we have got prospective ECG gated, and we have got this single heartbeat one, either with the 320 detector array or with the flash mode of the dual source CT. And each one of has its strengths. So when we are using the helical retrospective ECG gated one, we can get the LV function analysis. With irregular heart rate, it can work. While we are using the prospective ECG triggered sequential, axial sequential scanning, it needs a slow heart rate, and it has to be very, very regular. But it has got the least radiation. And then we have got the last one, either with the 320 detector or with the dual source CT flash mode, where you can get the entire CT coronary angiogram in one cardiac cycle. But obviously, whether it doesn't need any ECG gating, it doesn't need any breath hold. It is useful in both atrial fibrillation patients, also in bariatric patients also. Then so summary of the techniques for improving the temporal resolution, either we go for multi-sector reconstruction or you go for a dual tube, the way the Siemens dual source CT. And for a faster volume coverage, either we go for a larger detector array like 320 in Toshiba, or you go for the flash mode of the dual source Siemens cardiac CT. As we know, the application of cardiac CT is threefold. One is the calcium scoring, where you generally do the axial sequential. Then you have got a coronary CT angio, where you can do either the prospective axial sequential or retrospective helical, or the single cardiac cycle. Then you can have the functional imaging for the left ventricular and right ventricular contraction and the movements of the prosthetic wall, so and so forth.
Yeah. Okay, I think that was the technical part of it. And I think in the next MMI series, we will look at the cases of CT coronary and the calcium score. I think that part, Dr. Johan Christopher will take it.
Yeah, we'll take that, and that will be a sort of a very good clinical discussion.
Yeah.
Now, any comments by James or any clarification by the faculty? Because he has, in the last 4 sessions, he has very nicely discussed the technical aspects of CT angio, and now in the next one, of course, it will be clinically based topics or so.
Yes, sir.
Now,
Sir, so far we don't have any questions in the chat, but let me just ask you, sir. Thank you for the great presentation. I think these are few points which we cardiologists usually ignore or we take for granted. That is the technical aspects. So just to start off the discussion, can I ask you, sir, for example, in my hospital, in the hospital which I previously used to work, we had a 256 slide CT. So can you please tell me, for example, if I am going for a coronary imaging, that is definitely that will be a plus point. That is, we can have a better resolution, and we used to have a GE machine. Two things which I would like to ask you or to share your expertise. That is, when should we go for a higher slice CT? That is 64 versus 256. For example, GE has this 256 dual core, which they say that it comes to 512. So when should we go for 256, or when should we or when is 64 really enough? And second thing is, whenever we send patients for CT, especially CT coronary angiogram, this is more of a practical question, sir. That is, we have the phone call from the CT people, sir, the heart rate is high. So how should we reduce the heart rate? For the benefit of all the delegates, I would like you to discuss on your protocol for the heart rate control, especially for CT coronary angiogram. And lastly, the third question, structural versus coronary. So how do you have any specific requirements from the technical aspect? So these are the three questions which I would like you to start on the discussion, sir.
Yeah. So the first question was about the number of slices that you want, okay, and whether it is dual source versus the large. So because we want to improve the temporal resolution, and also we want to improve the volume coverage very fast. So both of them work very well, whether it is dual source scanner or whether it is a very large array scanner. So every company I think has addressed that issue by different ways. Okay. So some of them are going for say 256 or 320 kind of slices. So that means only the detector array is larger. While in dual source, what happens? You have got two X-ray tubes and each one is having its own detector array. So what happens is the cost of the machine keeps on increasing. Whether
Yes.
you have got a extensive arrays or you have got a dual source, both will give you this equal kind of volume coverage also and good temporal and spatial resolution. But Siemens has acquired by using the dual source, while the others are trying to increase the number of arrays or increasing the number of slices. But that only keeps on adding the cost of the machine. So if you have got a very large volume, then these are viable options. But otherwise, for all these centers, a simple 64 slice CT generally suffices for the patients where you have achieved a good heart rate and which he can have a decent breath hold. I think even the 64 is almost like a workhorse for most of the centers. Okay, but the higher centers obviously will have an advantage, especially if they are doing pediatric work also. Then they will have advantage with the dual source or with the large scanners, large array of detectors, like whatever you call 128 slice, 256 slice, and so on and so forth. So that is one thing. Then now with the photon counting city coming in, which is very expensive because almost it goes in for almost 40 crores kind of a thing, but that is going to give an extraordinary resolution. And those again will, I think those again will be afforded by a very high volume centers. So currently they will not penetrate. So currently I think the workhorse is a regular 64 slice city with that.
Yes.
Secondly, we want to get those coronaries in that small window of diastole. Okay. And we don't want any motion artifacts during that period. So that is, we have got only one window available in that diastole, or you have got another window at end systole. So these are the, and these windows are determined by the speed of rotation of the gantry. So, so that is why lower the heart rate you have, lesser will be the movement artifacts of the coronaries. Especially the right coronary is the worst because it has got the largest motion. So that is why having the lowest heart rate is the best thing. I mean, someone would definitely like a heart rate of 40. That will be the best. But obviously, it is clinically not achievable. But I think we should strive to get at least 60 for the best coronary resolution. So our protocol is that at least I start 48 hours before beta blockers and evaporated both. Okay, but
Okay.
and ask them to start them as early as possible. But most of our cardiac patients are already on beta blockers, so actually it is much easier. But I also add then evaporated into it. Also ask them that the day they come, also morning you take it. Okay, so that they take it in the morning also, and then I ask them to carry the tablets with them to the city, so that even if they are not, they can, you can give it. Or lastly, you can give IV beta blocker also, so that should not be a problem.
So shall I interrupt
Generally,
you for a
pardon?
brief second? Sir, we give beta blockers and ivapiradine, and sometimes when the patient goes into the console or when the patient is in the gantry,
Anxious,
the
yeah,
heart rate increases.
correct. So
How do you manage it?
yeah, so generally
Because
they
mostly
go, they
doing
become
not much.
slightly anxious. Yeah, they go. So then also you need a sublingual nitrate to get the coronary vasodilatation. Then generally the small rise in the heart rates you can nullify by making the patient more comfortable, or give
Okay.
another IV 4 to 5 milligram of beta lock. This is very easy. 1 milligram per minute you can give it to 4 to 5 milligram. And finally you can also give some anti-anxiety like sublingual those tablets of anti-anxiety. So I think with that also you can manage it to keep the heart rate. But keeping the heart rate low is really, really important, and the heart rate has to be very regular. Never send any patient to the CT with an irregular heart rate, because you are going to get a lot of step artifacts because you are stitching those volume data sets. So that is why we covered all those technical aspects for this, because cardiologists should not take for granted. They feel the way we do echo, there is a lot of luxury. You can do entire volume very fast without breath holds and so on and so forth. The other techniques are not like, whether it is a CMR or CT, they have got lots of other challenges. Okay, so that is why this technical aspect we wanted to cover. And the last thing I think you asked was about the
Structural versus coronary.
structural, yeah.
Versus
Now the
coronary.
city is in a big way for the structural intervention, and as we know, tower planning is entirely city based. So you want a very high spatial resolution and image without any step artifact for the tower protocol. Okay. Now generally all the structural one, you need all the cardiac phases. So that is why if you have these dual source scanners or the scanners with a large number of slices, like large number of detector arrays, they are the best because the chances that you will get step artifact is the least in that. Then patient should have a regular heart rate, and there also I think if you have to control the heart rate. The radiation dose is definitely higher, but but many times you may not. Generally, you need a very high kV during the coronary evaluation. So many times the amperes go up during the diastolic phase, and rest of the time it is lower. So many times the structural images may be slightly lower quality, but they are good enough for the clinical purpose. So, but however, you are irradiating the patient throughout entire cardiac cycle for the entire 6 or 7 bits of scan. So obviously the radiation dose when you do it CT for structural imaging is obviously going to be much higher. But that is required, especially two places, definitely for tower and also for valve in wall in mitral position, because there you can now you have got softwares where you can actually put the new whichever wall you want into that city image and see how the LVOT will behave and how will be the new LVOT and so on and so forth. So so I think for city planning and mitral valve in wall, and in future when we'll have the tricuspid wall transcatheter valve implantation, we are going to need the structural city, and we will have to read the structural city very well.
Sir, thank you so much. Thank you so much for the input. Thank you so much. Parashar sir, any questions which you would like to ask?
No, because I'll just continue because of the time constraint.
I think now we'll move on to Parashar sir talk, that is non-rheumatic mitral
We
stenosis.
have always been discussing about a rheumatic heart disease, but we have always neglected a non-rheumatic disease also. And here I acknowledge the help of Dr. Manish Pansal and Ala Gesan to provide me just a few images or so. Now, as you know, the etiology of a rheumatic, of a valvular heart disease is especially mitral, primary, secondary, functional. Primary, rheumatic and rheumatic because that is the most common cause. But today we'll be discussing more about secondary and a functional one. Now, a rheumatic, is the major cause of all disease in developing countries. In Western countries, incidence of rheumatic heart disease is very less. As such, other etiologies are more important. So you see, this rheumatic heart disease is very well known to all to you. That a thickening of the cusp, a paradoxical motion of posterior cusp, doming and whatnot, that is all known to you very well. But the most thing is a commissural fusion, which is a sort of a hallmark of this. Now, it will mainly be a case-based presentation or some cases what we saw. Now, in coming to the secondary one, there is non-dramatic. A degenerative mitral stenosis is playing an important role. It is mostly seen in Western population because of increasing life expectancy and comorbidities, and degenerative MS has emerged as a very leading cause because the calcification extends to the other areas. We also see a lot of a degenerative mitral stenosis, but we try to overlook it because of a mitral annular calcification. So remember that when there is a mitral annular calcification, it reduces the diastolic annular expansion, and most of this calcium goes to the bases and the mid portions of the inflow orifice, and that can produce a sort of a mitral stenosis. And as you see, in a case of a degenerative mitral stenosis, the main lesion is at annulus. So there is no doming because the leaflets are not involved, while in the rheumatic mitral stenosis, the involvement is more of the leaflets. As a result of it, there is a doming of the leaflets. Now, this is not that uncommon, and in one of the big surveys, they found that the overall incidence of a degenerative mitral stenosis was 12.5%, And this increased to almost, as the age increases, it went on increasing, but the average was about 12.5%. Hence, it is not that uncommon. Now, here you see this was a case of a mitral annular calcification, a significant calcification of the mitral annulus. And as a habit, we put a color flow mapping and Doppler across it, and we found a mean gradient of about 6 millimeters of mercury, indicating the presence of a degenerative mitral stenosis. So just do not ignore it, but just see it for a time being or so. And this can also be seen in a 3D echo because you can see a marked sort of a calcification of the annulus or so. Now, the assessment of severity is a problem because the 2D planimeter area is difficult because of acoustic shadow. 3D echo only when the good quality imaging can be obtained. Otherwise, it may not be of a good health, although it is a promising method. A pressure half time because of the age, diastolic dysfunction, LVH, and other comorbidities, it overrates the mitral wall area. So a pressure half time is usually not used in these cases, but for the interest of those who are still interested in this condition, there is a condition known as a mitral wall dimensionless index, like an aortic wall. You divide the LVOT VTI by the mitral wall VTI. Now, as the mitral stenosis increases, the VTI will also increase. And when the VTI increases, the ratio becomes less. So usually the 0.31 to 0.04 is less than 1 centimeter, and we normally want it to be more than about 0.50. So this can be used, and it's a very simple method to use this dimensionless index. So the take-home message is, do not ignore mitral annular calcification just as an old age phenomena. Always interrogate it by CFM and Doppler and diagnosis as degenerative mitral stenosis and not just a mitral stenosis, but it is usually known as a degenerative mitral stenosis. Now, this is another young lady with a mitral stenosis. You see a doming of the leaflet or so. The mitral wall area was about 1.2 centimeters. Now when we went to the sort of a apical view, you see that the mean gradient are markedly increased and the area came down to 0.8 centimeters. So that the mitral wall area from 1.2 to 2D to a pressure half time came to 0.8 centimeter. So this gave us a hint that the stenosis is at a subvalvular level, and this was proved by it. And see, you see, now it can be rheumatic in majority of the cases, but can sometimes be found in a non-rheumatic cases. So I just brought it for two reasons, that this should not be ignored and should be checked when there is a discrepancy between the areas and the gradient between the mitral wall. And you see here the stenosis is more marked in the subvalvular region. So do not, so that means the source of information is the comparing the areas from a subcostal, from a apical view to the 2D area and the gradients at this level. Now, this was a lady who presented first in January 2005. Age at that time was 36 years. She had a controlled hypertension for 2 years and had cerebrovascular accident. That means at the age of 33 years only, with complete recovery. So when an echo then was somewhere else, she was diagnosed as a rheumatic valvular heart disease. And then she was referred to us prior to a mitral valve replacement, but usually there is a referral. And here you see no problem that there is a doming of the anterior mitral leaflet, a paradoxical motion of the posterior cusp, and like all the signs of mitral stenosis. But this gave us a diagnosis that we are not dealing with a rheumatic mitral stenosis. We'll come to it later on. And you see a color flow mapping showed a significant mitral stenosis and a regurgitation. That is why the patient was sent for a MVR. But here you see what we found was that there is a marked fibrosis of the mitral leaflets. The posterior leaflet shows a very poor motion. There is an endocardial thickening, and the main thing was that there was a thrombus at the LV apex. So this gave us a hint that that was the thrombotic stage of the hypereosinophilic syndrome, and because that was given by this diagnosis. And then when we went into the various of history, then there was a history of eosinophilia, and she was investigated always in detail. So that is by a complete echo, and you see a thrombus in absence in the presence of a normal mitral wall. So there is a substantial restriction of the posterior mitral leaflet, marked endomyocardial thickening, which was seen from various views, and there was apical obliteration by the thrombus, and there was a dense endocardial scarring. So this was a thrombotic stage of a hypereosinophilic syndrome. And after that, and luckily till next 10, 15 years, she never went into a fibrotic stage. So the problem in these cases was the diagnosis with a persistent and marked eosinophilia for more than 6 months, and eosinophilic mediated end organ damage, absence of a primary cause of eosinophilia. And the problem is surgical management issues in these cases because the walls are very prone to thrombosis. So the problem is that if you give a metallic wall, it is more prone to a thrombosis, but even a sort of other valve also can lead to this. So that is the issue of this management in these cases. So the attempt is made by a medical management, by steroids and other things also, and these come as a last issue. So this was an idiopathic hypertension syndrome producing this. This was a Kalsia Manish, a 48-year-old lady, was on anti-cancer treatment and reported with systolic murmur in the left sternal edge. And you see there was a thickening of all the cusps, whether it was the aortic wall, tricuspid wall, and a mitral wall. There was a thickening of all the cusps after this prolonged radiation therapy. And this was known as, this was a radiation-induced valvulitis. So nothing to do with a rheumatic heart disease, but a sort of a radiation-induced valvulitis following a breast cancer. And these patients have a usually very long latency period. So that is why when a patient is on a sort of a radiation therapy, more frequent echo should be done sometime to see for any valve involvement. And it has got a very long latent period with a degenerative process of thickening, fibrosis, and calcification. The mitral valve and aortic valve are more prone somehow the other, and annulus and the subvalvular apparatus may be affected. So these was the case of this, and the management becomes very difficult because the presence of chest wall scarring and concern for delayed bone because of radiation, presence of prior cardiac surgeries, calcified aorta, that many other problems are there. But nowadays they are trying to do some non-surgical intervention. But let us see how much we go into this. Now, these Liebman-Sachs endocarditis are known to produce a mitral stenosis. The Liebman-Sachs endocarditis presents as a sterile fibrin platelet thrombi like a vegetation on mitral and aortic wall, and is a type of a non-bacterial thrombotic endocarditis. And in cases of SLE and antiphospholipid syndrome, it is called as a Liebman-Sachs endocarditis. It can cause a progressive damage, leaflet thickening and stiffening of the wall, and sometimes cause a commissural fusion. So because of though the vegetations are sterile, but they can cause a leaflet thickening and stiffening of the wall. So this was a courtesy Sunil Mankar. You see a case of you see a vegetation in relation to the aortic wall, and this patient had a multiple CVAs at the age of 33-year-old, because these patients are known to have multiple arterial and the venous occlusions because of this antiphospholipid syndrome and these vegetations. So, and you see they can cause a sort of a vegetation wherever you want, the vegetations are here. And again, you see on the atrial aspect of these are the vegetations, and they can ultimately lead to a stenosis, an uncommon cause, but yet that should be kept in mind. Now, then there are other non-rheumatic pathologies. The congenital play a very important role. They can be at a supravalvular, valvular, or subvalvular region. They can be parachute mitral valve, Schoen complex, double orifice mitral valve, and many other associated lesions are known to produce. So they should be looked after. So this was an 18-year-old girl, dyspnea, easy fatigability, onset of hemoptysis, or murmur or suggestive of mitral stenosis, and she was referred for evaluation of a balloon mitral valvotomy. So, and when she came, she had a rare combination of both mitral stenosis and a membrane into the LA, obstruction at both the levels. It was difficult to see. Now, normally it can be a stenotic lesion of rheumatic, but this is a very rare combination seen where you see a stenosis both at the triatriatum level and at the mitral valve level, and these require more of a surgical intervention. So it is because of the rarity of these such cases we wanted to bring this case to you. A 26-year-old patient, asymptomatic, except for mild cough, clinically NAD, echocardiography was done for a routine detection. And here you found a sort of a double orifice mitral valve. You see there are two mitral orifices, one larger, one small, and this progressed into the mitral stenosis. So because they can go to the mitral stenosis, they are well known to it. Another patient of ours, you can see a double chambered mitral valve and both the sides, and they can have a sort. There are various classifications for this. There can be a bridge between the two orifices, or they can have a separate annulus, but they can sometimes be detected by just a routine examination. You see one flow coming from here, one flow coming from here, and these are the two orifices. And it is very rare and be split into two orifices separated by a ridge of fibrous tissue, may be asymptomatic unless there are other associated congenital lesions, which usually are bicuspid aortic valve, PDA, or a sort of a coarctation of aorta, and they usually go into a state of stenosis or a regurgitation. The previous patient went into a state of stenosis. Now, this is again, as you see, hypertension is symptomatic. There is stenosis at the obstruction at the level of mitral valve, aortic valve, subaortic membrane, submitral membrane, supra-aortic membrane. And again, at two levels, there was an obstruction. And then there was a coarctation of the aorta. So this was a partial Schoen complex. Schoen complex is when there is a multi-level left-sided obstruction. And this patient had an obstruction at the coarctation of aorta, obstruction at the mitral valve, and obstruction at the aortic valve. So this is known as a Schoen complex. So and it is usually a supravalvular membranes also in these cases. And this is again, you see this was a sort of, you can see a parachute mitral valve, again because of a single papillary muscle. It looks like this is not very, it is very common, not that common, but should be looked after. Finally, a transient hemodynamic mitral stenosis, which is non-rheumatic. You see, these are all well known to you. A left atrial myxoma producing a partial obstruction in the mitral valve because it goes into the LV during diastole, and you can see a sort of a flow acceleration and aliasing producing this. And this was another interesting case. LA myxoma presented with MS and severe MR. You see, there's a multiple myxoma here going into the mitral valve, and you see here, it shows a significant mitral regurgitation because normally they are supposed to produce more of a stenosis, but a regurgitation. But if you see them carefully, they produce the perforation of the mitral leaflet. So this perforation, because of a repeated stress on the mitral leaflet, because of this going into the airway, it produces a sort of an obstruction. And finally, these cases can produce an exacerbation of mitral stenosis. Now, this was the case of a sort of a fungal endocarditis present in the case of a mitral valve. And these fungal myocarditis can produce an added obstruction because of a because of these obstructions. So in summary, nothing to replace a good clinical history and examination. Always study every aspect of echo. Any abnormal finding, explain why it is present. Keep non-rheumatic lesions in mind with liberal use of CFM and Doppler, and non-rheumatic mitral stenosis usually have management issues. And we try to show you but 8 to 10 case-based studies to show that yes, they can be present and how to diagnose. Thank you very much.
Thank you, sir. Thank you for the detailed presentations and also especially the cases. I think we had a huge array of cases from mitral calcification, hypereosinophilic syndrome, cancer chemotherapy, Lippmann-Sachs, endocarditis, double out orifice mitral valve, Schwann's complex, and whatnot. Thank you so much for that. So I will just, sir, we had one question from chat box. So before going into that, I will just ask one question from myself that is for the benefit of all the delegates. When you're dealing with this rheumatic versus non-rheumatic, especially you have highlighted very well that it is the base versus tips. In rheumatic, it is a tip involvement. In other situations, maybe it is more of base. So there is one question is, sir, comparing continuous wave Doppler versus pulse wave Doppler in assessing the gradient. So do you have any favorites, for example, in different between?
Say I use both. Sometimes when there is a very mild mitral stenosis, first you use a CW, then I use a pulse Doppler. But theoretically, in any stenotic lesions, we have to use a CW Doppler. But sometimes by using, if the velocities and the gradients are very less, we have used a pulse Doppler and it has produced as a beautiful imaging, including a pressure half time. But as you say rightly, that for a general audience, they should be more comfortable with a CW Doppler because of an increased disease flow. And rheumatic acid, beside the thickening, it is the commissural fusion which gives us a diagnosis also. So it should be both, but first preference should be a sort of a CW Doppler.
Sir, thank you so much. And there is one question from the audience, that is, can we use explain at the mitral leaflet tip to measure mitral valve area in doubtful situations?
So you can always use a sort of a 3D echo in these cases. But what we discussed was a non-rheumatic mitral stenosis.
Exactly, sir.
As I told you that even in a degenerative mitral stenosis, you can use a 3D echo. But many of these can be fallacious because they depend upon the good imaging also. But otherwise, yes, a 3D echo always gives a better mitral valve area as compared to 2D echo.
Thank you, sir. Thank you so much for the case. And thank you so much for the cases. And thank you so much for the beautiful presentation. Nitin Burkale, sir, Dr. Shanmuga Sundaram, sir, any questions or any suggestion, any points which you would like to discuss?
Yes, sir, it is a great collection of cases, as you said. The hypereosinophilia with mitral involvement more commonly produces mitral regurgitation because of restriction of PML mobility. But sir showed a very unusual presentation of mitral stenosis along with
in our case also you see there was a significant mitral regurgitation, but stenosis was also there. But as you rightly said, that regurgitation definitely more common, which we showed in that particular case.
Yes, sir.
So I think we had two great talks on two very relevant topics, and From that, let us move on to some challenging complex cases, and we got none other than Dr. Shanmugha Sundaram sir to guide us through it. Sir, please go ahead.
Yeah. Is my screen visible now?
Yes, sir, very well.
Yeah.
Please go ahead.
Yeah, thank you for the opportunity. I presented this case recently in one of the IAE meeting. I'll just go over this case. It was an unusual case of acute heart failure which I recently came across. So it's a 55-year-old lady presented with a history of 10 days history of intermittent fever with a dry cough, along with exertion breathlessness associated with fever, and no definite angina, no other comorbidities like diabetes, hypertension, coronary artery disease. And she was a bit tachycardic at presentation. Her BP was normal. She had evidence of volume overload. Heart sounds were normal and no murmurs. And basic blood investigation showed mild anemia with elevated ESR, which is 58 millimeter per hour, and HbA1c was slightly elevated. Renal function was normal to begin with, and urine routine examination was normal. This was the ECG at the time of initial evaluation, which in fact showed evidence of prolonged PR interval. Otherwise, no significant abnormal finding. The chest X-ray showed cardiomegaly and pulmonary venous pulmonary vascular markings were normal. To like continue with the echocardiographic images, this is the parasternal long axis, which shows normal ventricular dimension and systolic function, and left atrial enlargement is noted with mitral leaflet and aortic valve were morphologically normal, and alveolar dimension was appearing normal, and the color across the aortic valve, no evidence of turbulence in LVOT. There's a trivial aortic regurgitation. There is no antegrade turbulence across aortic valve vessel. And there is mild regurgitation noted with a jet directed centrally. And the other prominent finding noted here is the pericardial collection, which is noted posterior to the left ventricle. And there is some collection noted anterior to the RV as well. And this is coming to the short axis views. Left ventricular dimension and contracted if all the segments appears normal. And what we could see is there is dilatation of right ventricle with the septal flattening, which is more prominent during diastole. Probably suggests a volume overload type of interventricular septal motion. And there is pericardial effusion, which as we noted in the parasternal long axis images. And this is the RV inflow view, shows there is significant tricuspid regurgitation. It's close to severe, as evidenced by the wider vena contracta. Coming to the apical fourth chamber, what we could see is significant biatrial enlargement. Both RA and LA are enlarged, and the LV dimension and systolic function appears preserved both in fourth chamber as well as long axis. And there is mild mitral regurgitation as we noted in the parasternal long axis, and there is significant tricuspid regurgitation noted as well. Coming to the diastology assessment, what we could see is the E velocity is nearly normal, so 1.1 meter per second, and A velocity was 0.23 with a E ratio of more than 4:1, with deceleration time is reduced, probably a restrictive mitral inflow pattern. There is no significant respiratory variation noted in the E velocity, since there was evidence of pericardial collection, though no obvious evidence of tamponade physiology here. This is the medial annular velocity, which is kind of 9.9 centimeter per second, and lateral annular velocity was slightly lower, almost 7.7 centimeter per second. In the presence of volume overload and features of heart failure, a preserved medial annular velocity raises the possibility of annulus paradoxus, that is basically which can raise a suspicion of constrictive pericarditis, which again there is some annulus reverses as well. We routinely see lateral annular velocity more than that of medial annular velocity, but here it is the other way around. So this again raises the possibility of annulus reverses. So with the effusion in the background, and there is a restrictive physiology and preserved medial annular velocity, and there is some reduction in the lateral annular velocity when compared to the medial annular. So is it a effusive constrictive physiology? Has to be thought of. So the left atrial enlargement was noted. The biplane LA volume was 105 ml, and there's the TR velocity. The TR velocity was less than 2.8 meter per second. And coming to the subcostal images, again showed pericardial collection with dilated IVC, which is not showing any significant respiratory variation. And hepatic venous Doppler shows there's no like systolic antigrade flow is blunted, and there is subtle reversal of systolic flow reversal noted as well. So further evaluation with that background, the CRP was elevated since he had a recent history of fever. So some kind of acute pericarditis was in suspicion at that point of time, and LFT was normal, thyroid function was normal again, and ultrasound abdomen showed mild right pleural effusion along with dilated IVC, no evidence of any organomegaly otherwise. So we had few differential diagnoses because of biatrial enlargement and restrictive physiology by Doppler. We thought of some kind of restrictive physiology along with pericardial effusion, but the point against was the E prime. The preserved E prime is not a feature of restrictive cardiomyopathies. The other possibility, as I discussed earlier, the pericardial effusion with probable effusive constrictive physiology. The points favoring was restrictive inflow pattern, annulus paradoxus, and probable annulus reverses. But the typical ventricular interdependence wasn't present, and hepatic venous Doppler was again not showing the diastolic hepatic diastolic flow reversal. That was again not fitting in. So we went ahead with CT thorax, which sorry, go back. Yeah, which just revealed that there was significant pericardial effusion with significant mediastinal lymphadenopathy. It was noted in the mediastinal right halar and cervical and periportal lymphadenopathy as well. So we thought we'll rule out tuberculosis, lymphoma, or any of the other etiologies as a cause for pericardial effusion. We requested our pulmonologist to get one endobronchial ultrasound guided FNAC, which in fact did not help us and did not reveal any etiological diagnosis, which was negative for granuloma and atypical cells. When I discussed with the pathologist, they said it was more likely a reactive lymphadenopathy, and we couldn't conclude anything from that. So ANA profile was negative, quantiferon TB gold was negative, serum ACE level was normal. So neither FNAC nor other biochemical or pathological features were supporting any other etiologies like lymphoma or sarcoid. Subsequently, the patient developed episodes of atrial fibrillation and had features of volume overload, continued to have breathlessness, started on apixaban because of atrial fibrillation and heart failure, along with the beta blockers and diuretics. So we thought whether to go ahead with further imaging or to look for any tissue diagnosis. So this was the echo when she had clinical deterioration. What we could see is again LV systolic function was normal, RVOT and aortic root was normal. There is some layering of structure which is noted within the left atrium. We at that point thought it was a layered thrombus, and this is the like tricuspid regurgitation, which in fact got worse over a period of time, and there is a pericardial collection as it was noted at the outside. Like we thought, without the pathology lies in the pericardium. At that point of time, we requested our surgeons just to drain out the fluid and get some pericardial sample, since we were desperately like looking for the evidence of any tuberculosis or any other disease which is causing this pathology. So it was in fact negative for granuloma malignancy, which in fact didn't help us at all. But when I discussed with the surgeon and cardiac anesthetist, they did intraop TE. This was the intraop TE images. What we could see is this is a left atrial appendage, mediasophageal 90-degree view, and all the other views showed there is significant layering of structure which is noted within the LA endocardium. So whether it is thrombus, whether it is something else, we weren't sure. So we thought we'll just go for other imaging like PET scan, which in fact came as for our rescue, which showed diffuse intense metabolic activity noted in the left atrium with significant wall thickening of the left atrium. They said it is likely to be a myocarditis, and very low-grade FDG, minimal pericardial thickening with trace pericardial effusion. No significant uptake noted in the ventricular myocardium. So, at this point, we could fairly say that it is likely to be an atrial myocarditis, query etiology with paroxysmal atrial fibrillation, normal left ventricular systolic function with pericardial effusion, probably reactive to the myocarditis, and no evidence of tamponade. Severe tricuspid regurgitation is related to the atrial enlargement because of atrial myocarditis. So that is atrial functional TR, and there was intermediate probability of pulmonary hypertension. So she was started on steroids with 1 milligram per kg per day, and along with beta blockers, diuretics, anticoagulants were continued, and calcium and vitamin D supplements because of high dose steroids. She definitely showed a good symptomatic improvement after 2 months of steroids. Volume overload improved and rhythm settled. No further episodes of atrial arrhythmias, and she had good symptomatic improvement as well. This was the echo after initial course of steroids, where the layer structure, which was in fact thickened atrial endocardium, which totally resolved, and no further thickening noted here. And the pericardial effusion had come down, what you could see, and there is subtle reduction in the LA dimension also. This is the short axis again. There is a significant reduction in the pericardial collection. And this is a fourth chamber, what you could see. There's a significant biatrial enlargement to begin with. There is a definite reduction in the atrial dimensions after the course of steroids. This was a severe TR to begin with, and now it is trivial to mild tricuspid regurgitation. And atrial volumes, this was atrial biplanar volume was 105 ml, and like after the course of steroids, it has definitely reduced in size. This is mitral inflow Doppler to after the course of steroids. It was not the A ratio that had come down. This was the annular velocities and TR. Now the TR velocity is 2.1 meter per second, and this is a subcostal view showing a significant reduction in the IVC dimension, as well as variability during respiration as well. So she's symptomatically better with no further evidence of volume overload. She's in sinus rhythm, no further episodes of AF. Diuretics could be stopped over a period of time, and on beta blockers, anticoagulants, and tapering dose of steroids. CRP had come down from 50s to 8. So plan is to continue steroids for 6 months and watch for relapse after stopping steroids, and to decide on the need for immunosuppressants if there is any recurrence of myocarditis while tapering or stopping steroids, and to continue anticoagulation, and to assess LA strain during follow-up to assess the need for subsequent anticoagulation as an index for atrial mechanical activity. So probably what, like, I mean, we could have gone for a PET scan in the beginning, which might have avoided the pericardial biopsy, or having gone for pericardial biopsy, probably had we known that it is an atrial pathology, we could have just got a sample from a left atrial appendage or anything, which could have proven the real etiology of this atrial myocarditis, whether it is giant cell or viral lymphocytic myocarditis or anything. So probably the sequence of investigation could have been better, which for the treatment might not have changed. In fact, like when we went through the literature, there was a similar case just reported with a similar appearance of layering appearance within the left atrium because of LA myocarditis. Again, PET scan showed an uptake in the left atrium alone, with CT again showing the thickening of left atrial wall, where they diagnosed it as atrial myocarditis. So there was a series in a Mayo Clinic where the most common etiology was noted to have been, giant cell myocarditis. There were other reported causes like sarcoidosis or lymphocytic myocarditis. So the atrial arrhythmias are associated most commonly AF, atrial mechanical dysfunction, increase the risk of thrombosis and thromboembolism. Obviously, there is a definite indication for anticoagulation. So we for evaluation of inflammatory markers and multimodality imaging is the key. Biopsy had been done. There were reported cases of intraatrial septal biopsy, which yielded the diagnosis. Obviously, we need to rule out other etiologies like malignancies, sarcoidosis, lymphoma, or anything infiltrating the atrial endocardium. So in this, the reported treatment were immunosuppression, either steroids alone or steroids with immunosuppression. And duration of immunosuppression is not very clear because it is a rarity. Prognosis of atrial giant cell myocarditis appears to be much better than that of ventricular giant cell myocarditis, which has a very poor long-term outcome. And natural causes and pathogenesis also seem to be different from that of isolated atrial myocarditis. So to conclude, dilated atria with diffusely thickened atrial wall, keep atrial myocarditis in mind. And multimodality imaging is the cornerstone in diagnosis. It responds very well for immunosuppression as it did in our case. Thank you.
Well, a great case. Can you hear me?
Yes, sir.
Yes, sir, please go ahead.
Can you slightly elaborate on diffusely thickened atrial wall? Number one, how much thickened, how can you say? Then could have LS strain be of some help in these cases, earlier stages?
Sir, regarding the magnitude of thickening, in fact, when we saw this, I'll just go to this first slide. When we saw this case first time, retrospectively, when we reviewed the image, even at that time itself, we could notice some thickening of, yeah, I'll just go over these images. Yeah, if you just notice this image, even here, there is some layering noted, but which in fact got worse over a period of time. And when we saw her after the clinical worsening, where the thickening appeared more. So regarding the magnitude of thickening and to suspect this endocardial inflammation, I'm not sure whether we can say that we could identify only if it is significantly thickened endocardium as we saw during the subsequent clinical worsening. This was the first finding, which in fact we missed during the initial echo. So probably if we are careful, we can identify this thickening early, but I mean, we are most likely to overlook this as some kind of artifact if it is a mild thickening. So I'm not really sure regarding the magnitude of thickening and whether there is any number. No, I couldn't really come across any number to suspect atrial endocardial thickening over any other diagnosis. And regarding strain, yes, probably it would have given us a clue about the atrial function. Probably reduced reservoir strain and reduced contractile strain would have given some evidence, but that obviously can happen with paroxysmal like atrial fibrillation or atrial mechanical dysfunction or atrial cardiomyopathy, which is being discussed nowadays. So which could have told about that, probably not really would have given a clue regarding the atrial myocarditis as such.
Good. Very good case.
Thank you, sir.
It's a very, very interesting and challenging cases and amazing response to steroids.
That's true.
Yeah, it was great. Just want to ask you one question regarding the septal motion initially. So can you explain that just based upon because of the tricuspid regurgitation or any other?
Yeah, in fact, I couldn't see any respiratory variation in the septal position, and there was flattening of septum, which was more noted during diastole than systole. So we presume that it is related to the tricuspid regurgitation and volume overload, the low pressure TR the patient had. Though the constrictive physiology was there in the differential diagnosis, the septal motion wasn't typical since I didn't find the respiratory variation in the septal position.
I think it's an amazing case. Parashar sir, have you seen anything like this in your?
No, I think it was very. At that time, we never went into such thorough investigations or so. That was the thing.
I think hats off to
Well,
you.
I will say,
For this wonderful.
Thank you.
Shanmuga Sundam, I would suggest that because you have read so much in the September issue of the Jays, there's a beautiful article on reversers. Just read it.
Sure, sir.
Not annulus, but the other reversers. It's very nice. That is for your interest. Very nice. Just September issue. Very good article on reversers.
Definitely, sir.
Train reversers on me, sir.
Definitely.
Okay.
Thank you.
Dr.
Simi,
Simi,
any question from?
Dr. Simi, any comments? Dr. Nidin, any comments?
There's one last question. I don't know. I don't think we've covered it. Does mitral arcade cause mitral stenosis? So
I
this
mean, the
is
question is to you, Parasar sir.
this is
Sir,
a
said anything which involve the fibrosis and thickening of the mitral wall can cause stenosis also. Anything. So that is there, but any Shanmuga Sundaram can answer it or not. But because anything, any lesion which can cause some sort of a thickening of the mitral leaflet can cause a stenosis also. But if we
Yes,
had
sir.
seen such cases, we would have presented it today. Huh?
Yes, sir.
and there's a question for Dr. Shanmugasundaram also. Was it viral myocarditis and any viral markers were done in your case?
We didn't do a viral marker. It could be a viral myocarditis. Most likely, yes, because of the recent history of fever and a short clinical presentation. Most likely, yes. As I told you, like probably had we taken a biopsy from a left atrial appendage or anything, which would have yielded the histopathological diagnosis exactly, but we didn't do it.
And just for my clarification, I just missed that part. What was actually surgically done exactly? Surgically, what was?
We just got a pericardial biopsy.
That's all.
Yeah, we just we didn't do a pericardectomy, just left atrial thoracotomy and then the pericardial biopsy.
I actually, when did you decide? I mean, what was the initial surgical plan? That was just to go with the pericardial biopsy, or just
Yeah,
to...
it was just for a tissue diagnosis. So like surgeon, in fact, was asking me whether to do a pericardectomy as well. But I mean, there was real no evidence of pericardial thickening, just an effusion with some doubtful effusive constrictive physiology. So we didn't like we were not very keen to send the patient for pericardectomy. So we thought just for tissue diagnosis, whether are we missing a tuberculosis was my primary concern. So to make sure that I'm not missing tuberculosis, we went ahead with pericardial biopsy.
Dr. Shanmugasundaram, hats off to you, because two things. One is you got such a teamwork between you and the surgeon, because if you do a biopsy and ultimately then you feel that later you come back to the surgeon and say that, sir, I feel this is congestive pericarditis, can you do the pericardectomy? He will kill you. So I think the conviction of not asking the surgeon not to do the pericardectomy, just do a pericardial biopsy for the tissue diagnosis. I appreciate you for that for the guts to do that, because I think that basically is probably because the way you have analyzed the case. That is, I don't think the surgeon will be pleased if you will come back to him again and ask him to do a surgery again and tend to do a pericardectomy. So my appreciation to you particularly.
Yeah, really, thank you.
Thank you so much.
Thank you.
Sir, Parasa sir, any closing comments before we wind up?
No, but I wanted to know that when they did the PET scan and everything and they found lesion in left atrium, did they find some lesion in the right atrium also or not?
Sir, they didn't mention that there was significant. I, in fact, retrospectively, I mean, asked them because there was a right atrial dilatation, there was severe TR, atrial functional TR. They couldn't really identify right atrial involvement. Possibly there would have been an inflammation there, not picked up by the PET scan. Probably that was not sensitive enough to pick up right atrial inflammation. That was
Well,
my
James,
impression.
you are the boss today. You have to give a concluding remark because you are the boss
Thank you
today.
so much. Thank you so much for the
We
opportunity.
really
Parasa sir.
like the cases and everything. Huh?
Yeah, I think thank you. We had two great talks and one very challenging case. And my sincere thanks to Dr. Nitin Borkale for again coming up and teaching us in a topic which we are least familiar with. That is the finer aspects of cardiac CT. Thank you so much. We learned so much. And again, the non-rheumatic mitral stenosis, like Dr. Parasar sir said, mitral stenosis, rheumatic, we are all familiar. So dealing and going into those uncharted territories, and especially with cases, the entire spectrum of non-mitral rheumatic stenosis was covered. And thank you for that. And the icing on the cake was, I think, the case from Dr. Shanmugasundaram. Thank you so much for that. I think we all had a wonderful evening full of learning. So I thank the IAE for this academic initiative. I'm sure that the audience must have really benefited out of this. Thank you so much.
Thank you.
Thank you to
Thank
all
you.
the speakers And thank you to all the delegates, and thank you to the Central IAE for arranging this webinar. Thank you so much.
Thank you and good night. Bye-bye.
Night.
I
Good
think
night.
we can leave.
Yeah, thank you.
Thank you so much.